So I'm going to introduce you first of all to Carol and Fiona, who are going to share their experiences so far with working with long COVID group clinics. Over to you. Thank you.
Thank you, Helen. My name's Fiona Parker. I'm the admin team lead for the long COVID pathway, and I also work as a facilitator in the virtual group clinics. We've changed it slightly and we call them virtual group assessments. So if I talk about virtual group assessments, it's the same thing as the virtual group clinics. I'll be going through the first few slides, and then my colleague Carol Blackwell, who's the clinical pathway rehabilitation coordinator, will take over. Could I have the next slide, please? Okay, so I'll just give you a very short background about the long COVID pathway. It was set up approximately 2 years ago, and this was in response to patients who were still suffering with symptoms such as fatigue and breathlessness 12 weeks after contracting COVID, and no other causes were found for these symptoms. Our service is under the Actors One umbrella, and this is shared between 3 trusts: Airedale Foundation Trust, Bradford District Care Trust, and Bradford Teaching Hospitals. Could I have the next slide, please? We run clinics from Bingley Health Centre, Bradford University, Horton Park, Skipton Hospital. We don't have an official office space and all staff work from home predominantly. So the challenges that we faced with the volume of patients, because we'd had approximately 1,000 patients referred to us and we covered such a vast area. We've got Bradford and surrounding towns, we have Keighley, Skipton, and then we have a lot of outlying little villages such as Buckden and Grassington. So because of the sheer number of the patients that we had and the vast area that the service covers, we needed something that would allow the clinicians to see more than one patient at a time, and without the need for the patients to come into clinics, because in some of these little villages, it's very, very difficult for transport for people who don't have their own cars. Could I have the next slide, please? Oh, sorry. And it was also to stop duplication of conversations with all the patients as well. So the virtual group clinics seemed the ideal way to create a safe space for patients to offload and reduce this duplication of conversations. We found that many patients were suffering with the same symptoms, and it allows the patients to see that they're not alone, and the patients are generally really supportive of each other. And some patients that are further along in their recovery share helpful suggestions of what have helped them. And we do see a good response. The amount of patients that say, I felt so alone, and it's so nice to hear that other people are feeling the same way. So this is our virtual group clinic model. What happens with the patients to start with? They fill in a registration on the C19's YRS, which is an online app, and they put the symptoms in there, when they contracted COVID, how they're feeling, and then that's given to the clinical assessor, who goes through the information that the GP has given, the information that the patient has put on the app, and then they assess whether they feel it is long COVID and whether they need to be invited into clinic. Then the next stage after this assessment by the coordinator is the objective assessment clinic, and that's where the patient comes into clinic. They get baseline results done, such as heart rate, blood pressure, oxygen saturation rates. They do stand to sit tests, and depending on the outcome of those, they may get called back for further tests. But if everything's okay with that, that's where our virtual group assessment comes in. They're then invited to the virtual group assessment where they can ask the clinician questions about their health. So at this point, I'll pass over to Carol, if that's okay.
Thank you, Fiona. Yeah. So as you can see, our assessment is a 3-part assessment. So it's the following the registration and the C19 app completed. So our coordinator assessment is undertaken, followed by the objective clinic, and then our virtual group assessment is that first opportunity for the coordinator. So the coordinator who does the assessment also do the virtual group assessment. So that's myself and my colleague who's also a coordinator. And then we have another assessor who's due to come on. So that our group assessment, the clinicians that we do is, I'm an OT by background and Jez is a physio by background. So we run the virtual group assessment in that particular format at that particular stage. We'll talk a little bit more about the impact of the group having, but that's where it fits within our pathway. We then have a virtual 7-week-long course, which is an education course, which is run very differently from a virtual group clinic. And then following that, it's an education 7-week session on the various different symptoms about symptom management, but it's purely educational. Following that, we would then invite people back to a second virtual group review and a virtual group clinic. At that point, we then identify other goals, other needs, and then refer on for our therapy intervention. And at that point, we move them over into the rehab phase of their recovery. And our therapy intervention consists of various different groups that our multidisciplinary team run. For example, brain fog, mindfulness, sleep course, fatigue management. We have a breathing pattern disorder group. We have functioning around breathlessness, a deconditioning one, and then we have mental health groups, psychoeducation sessions as well as voice therapy and vocal care sessions. But we have a number of groups that we run into that. Once they've done 1 or 2 of the groups, we would then invite them back to a virtual group clinic format again, but that's what we call a virtual group review. And that won't be ourselves as the coordinators, that would be one of the other clinicians. At the moment, we have our mental health nurse that runs the review clinics as well. So the format is exactly the same as the VGC model, but the outcome is slightly different because it's a review model. Okay. Next slide, please. So what was the impact of us introducing this into our model? Well, we've had really, really positive impact. We've had really good anecdotal feedback on how people feel like for the first time, they've lived with long COVID for quite a long time. Some of them have been living with it for 12 months or more. And then they feel validated within the group, they have the opportunity to share, and they really value that experience of being able to see a clinician face to face and have that dedicated time, but also hear other people and their experiences and share their experiences, and it's really positive outcome. The impact on us as staff is that as coordinators, before we introduced the VGCs, we were really, really struggling with our waiting list, really struggling with our initial assessments, struggling on how we could give the dedicated time with only 2 of us, and our waiting list was creeping up and up and up. And the graph you can see just at the bottom can see when, yes, we have had a reduction in number of patients referred to us, but however, we've had a real reduction in the length of wait because we've introduced these virtual group clinics. We can see patients in there. Our initial assessment, or rather our triage as coordinator, doesn't have to be a full-on one-to-one, and so therefore we can get through those quicker and we can get through the process and see them in the clinic. So it has had a huge impact on our waiting list as well. Our waiting list is now it's definitely under 6 weeks as of last week, so we're really, really pleased with that. It had crept up and up and up, and we were at the point of like wondering how on earth we were going to implode with the with the waiting list that we had. But by introducing this type of group format and this type of group clinic, we've had a real impact, and the credit is to running it in this way and the pathway being developed. Next slide, please. So our next steps within the pathway here at Bradford and District is that we have obviously virtual group assessments fully integrated into our pathway, and it's routine now. We run at least 2 a week, 3 a week as well, between 3 of us. We have 3 clinicians that are running the group assessments, and we have 2 to 3 facilitators, Fiona being one of them, and then 2 other admin and assistant supports that run as the facilitators. We offer the clinic, the virtual group assessments at different times of day to meet the service user needs. So in an evening at 4:30, for example, to catch the end of year, half term as well. We've just done one this morning to meet like anyone who's teachers or needing school holidays that are able to attend. We started the virtual group reviews in January with really good initial feedback as well, looking at much more of a peer supervision, a peer group format as well, looking at what's worked well, what's not worked well, and then in order to guide them on where to go next along the pathway. We have got 22 groups on the pathway that we're running the rehab element of it, but we're looking at ways in which the ethos of the virtual group clinic can be incorporated into these groups a little bit more as well, because we find a huge benefit the way we run the virtual group clinics. We're reviewing the group procedures so that, as I say, they all match the safety mechanisms of the confidentiality as well. That's been a really good move as well, and what we've learned a lot by doing the virtual group clinics on how important information governance and confidentiality is, so that ethos works well within some of the other groups that we run. We're also looking at promoting that format across other local service areas. So we're wanting to introduce the idea and the way we run our virtual group clinics to other clinical areas, such as life after stroke, pulmonary rehab, and our respiratory outpatient service as well certainly within Airedale NHS Trust as well. We're doing a talk next month about that as well. And also we've talked a long time about considering self-referral into the service and how this would fit into the virtual group clinics. Up to recently, we haven't had the availability to be able to consider this, but now that we've worked so hard and now got the waiting list under 6 weeks, we are looking at promoting this within our primary care network, within the GP practices as well, to look at how we promote this now as well. And next slide, please. I think that's it. Oh, yeah. So our advice, final and foremost, actually, to making the change to running virtual group clinics is being brave, to have a go, to try it. It's not easy, and it takes practice. Be prepared. So plan is absolutely vital to knowing how to work it, what to do, to practice, give yourself a simulated go at it first before the real thing. Trying to develop a change culture as well, so that actually groups aren't there just to be educated to. They're there for peer and facilitation in order for the patients and the service users to get the best out of the groups that they can by attending it. And supporting the staff, which it can be really daunting. For some of us, certainly myself and Fiona, at the very beginning, we were so nervous. We still are from time to time, but it's about having a go and just keep practicing, allowing staff members who are thinking of taking the change to shadow and observe the group format as well, because it's a new way of working, and absolutely trust the car park. It's vital. We get so much from using the car park, so that we know where and who and when to refer on and things, because we can't always remember when we've got a group of 6 to 8 patients in there. We can't always remember everything. So trusting the car park is absolutely vital. Is there anything else you wanted to say, Fiona, from the admin side, from the facilitator side on that point?
No, I think you've covered it really well.
Okay, that's fine.
Yeah.
So thank you so much for
just
listening.
No problem, Carol. I would absolutely I'm actually grinning all over my face here listening to you talking about that, and I just know how powerful it's going to be for some of the people on the call who are maybe thinking about going down this route, to hear your real life experiences. Thank you so much. I really loved how you've embraced the culture within the group clinic, and how you've seen that is very different from a group education session. And that came across really well. We haven't had any questions in the chat, so don't worry, if you've got questions, just pop them into the chat and we'll pick them up after the second speaker. So let's go across to our lovely ladies in Swansea now.
Oh, thank you very much. Hi everyone, and I'd just like to say on that point, Carol, I agree entirely, and I'm sure Sarah will with your last slide. So that was perfect. So and a fantastic presentation. Thank you. So really, we're just going to show you our approach in Swansea Bay. I'm Nick Perry-Gower. I lead the pulmonary rehab service, and I also coordinate the long COVID service for Swansea Bay. And Sarah is one of our fantastic GP leads in long COVID with a special interest in lifestyle medicine. Next slide, please. Thank you. So I'm going to give you a brief, and I promise a brief overview of our long COVID service and how we've got to where we are now. And then Sarah will talk more about the actual VGCs themselves. So we started our long COVID service really in September of 2020, which was quite early on in the aftermath at the start of the pandemic. So we started to see patients from a pulmonary rehab point of view, mainly who had been on ITU and then admitted to hospital, as was the case in many areas. So as I've said, I lead the pulmonary rehab service as it was seen as a respiratory virus with lots of overlapping symptoms. We really decided that we would support these patients. We, like everybody else, had limited evidence and information, but we saw the need, and then Swansea Bay's long COVID service was born, really. So initially it was community multidisciplinary team visits. Our referral numbers then started to increase, as has everybody else's, and that's a really important thing to say. So we developed then a very similar model to our pulmonary rehab service for our patients, so which was an 8-week course of education and exercise where appropriate, led by a multi-professional team, so physios, respiratory nurses, occupational therapists, dietitians, and exercise instructors. So we've got that really holistic approach in there. So the year went on, evidence continued to emerge, didn't it, about long COVID, and then Welsh Government then provided the AdFeriad or recovery monies for every health board in Wales. So it did mean that we could reevaluate our services and hopefully then look at improving it. It was short-term funding, so limited, but nonetheless really, really useful, extremely important, as it meant we could employ 6 sessions of a GP. So we know long COVID, as you all do, is a diagnosis exclusion, but we knew we needed more medical screening and advice for our patients. But we were really extremely keen, however, not to over medicalise our patients, and both our GPs are specialists in lifestyle medicine. So as alluded to, short-term funding was provided by Welsh Government, but due to the nature of short-term monies, as everybody knows, we were unable to recruit vital MDT staff that we needed to increase the capacity of our rehab model. So we were starting to see at least 30 referrals in both our localities a month, and it's increasing. So we were only able to provide 1 actual rehabilitation course at a time in each area due to our capacity and obviously our other pulmonary rehab commitments. So this saw a dramatic rise, as has already been said, in our waiting lists, and it was over 8 months, which isn't good at all for our patients. So we really had to consider how we could reach more patients in a timely manner, but also with that most appropriate intervention. Not every one of our patients actually needed face-to-face rehabilitation. Some were either too well for that, or some were actually too unwell. So we needed to think of something else. We needed a few more tools in our toolkit. So our pathway at this point was referral received, and that was mainly from primary care, and our GPs developed the criteria to send out into primary care. So with what tests needed to be done, what information we needed, they were triaged by our pulmonary rehab team and then put on a waiting list for a GP one-to-one assessment call. If suitable from that call, then the patient would sit on a waiting list for our face-to-face rehab. And we'd also got a resource list that we would send out as well. So obviously, like I've said, our waiting list was quite high because of that. So we knew we needed to improve that waiting list, and we also knew that not every patient, as I've said, needed that full face-to-face rehab. So this is where our virtual group consultations come in, and the guidance and the expertise, thankfully, from the ELC and Helen. We were able to look at a virtual solution or part solution, and this is where really I hand over to Sarah. So thank you.
Thanks, Nick. Yeah, thank you. Yeah, so as Nick said, really, we well, next slide, please, Helen. We had great meetings with Helen to help us get organised in this pathway and delivering the group clinics, and that gave us, the training as well that we attended definitely gave us the confidence to give it a go. As as Carol said, really just being brave. It was really nerve-wracking at first. So in our pathway, either myself or my colleague, the GP Kate, will have an assessment phone call before the virtual group clinic. So, and then it's during this that we'll decide about suitability, whether they seem to be, as Nick said, suitable for virtual group clinic, or whether they're more suitable for that face-to-face rehab course. So if VGC is thought to be best and the patient agrees, we take down their details on that spreadsheet for the next virtual group clinic. I think really, as Georgina was saying earlier, that those details are really helpful, sort of in the administrative side of it, to have a spreadsheet with their contact number, their location, and their email. So it's things like that when we're on the phone to remember that they need to have all that information from the patient. And also, as Georgina said, a password like a pet's name or something that they can. And we often have to remember to ask them for a hint, because it's easy with the brain fog to not remember that on the day. But then when it comes to the week before the virtual group clinic, our brilliant administrator Kim, she sends out the emails to the group, BCCing them, of course, so they don't get anybody else's email address, and she attaches our team invite. So with the team invite, there's also attachments of a virtual group clinic policy and a virtual group clinic frequently asked questions, so that patients sort of know what they're expecting. Because we have spoken to them on the phone, we've normally explained it a bit in advance as well. So the virtual group policy is really similar to what Georgina was explaining. It's explaining that the patient's happy to share that information or some information about their condition, which relates to long COVID, for example, the date they had COVID and their primary concerns, and explaining that those will be shared on a results board. And that also in explaining that they'll have time one-on-one with the clinician to discuss their concerns, and that other people will be able to hear this, and they can therefore also listen to other people's consultations as well, so that everyone's got the benefit of hearing and understanding these common problems and hopefully solutions. And also explaining that they've no obligation to share any other personal information, and if they prefer a one-to-one, then they can ask for that. That hasn't happened so far in the virtual clinics, I think, because they've had a one-to-one consultation already with the GP beforehand, so with ourselves in the pathway. But they obviously have that opportunity, and also it lets them know that they can withdraw their consent to participate in the virtual group clinic at any time if they would want. And of course, like Georgina was saying, that they must also agree in advance not to record or share any information about other conversations in the group. And we've also got a late policy that if they are over 5 minutes, or it might be a little bit more than that, then they can't be admitted and carried on, because they will have missed that security information, really. So yeah, moving on to the next slide, please. It's similar to what Georgina has shared already, really, but we do keep the times fairly light, so that we make sure we don't overrun too much. So that's just an example of what we've got one tomorrow, actually, that what we'll be doing. So we meet in advance, and the facilitator and the clinician, and the facilitator checks everything's working and starts when the patients start arriving, doing those security and location checks. And then the facilitator does the slides reminding patients about those confidentiality aspects. And then that's when we do the group confidence score, which is similar to the confidence score that you've done at the beginning of this webinar. And we average that out as well to give a group confidence score, and use that as one of our evaluation markers. And then we'll go on to show the results board that we've talked about already, and that will stimulate those general questions, really. And that's when we come in as the clinician, and obviously introduce ourselves and look at those questions. And I think one of the biggest things that I've learned is to not launch in and answer the questions how I think they should be answered, but to try and take a breath. My colleague always says, take a breath and reflect it back to the group, because that's when they, often other people have had experience in this, and sharing their own story seems to be really valuable and really helpful to other people, rather than me or another clinician saying what they think. So so that's one of the things. So for example, something about asking, finding it very tiring or fatiguing, doing jobs around the house, and asking other people what their experiences is and what they could, what they find helpful, and that often starts discussion about pacing and prioritizing, for example. And during the one-to-one consultation, they normally, hopefully they'll have had a lot of things addressed within the open discussion, but if there's other things that are particularly pertinent to them, they can raise it if they want to, of course. And we can go through that. And then the facilitator at the end will ask for, we'll sort of close the VGC by asking for new confidence scores and share any SMART goals, and then reflect in any improvements. We ask for any what's WWW, what went well, which I expect we might do at the end of this webinar, and then or any I for any improvements. And we've really stuck to those, and they've been really helpful to get people's feedback as well. So yeah, if you go to the next slide, please. So yes, we don't need to dwell too much on this. This is our slide, which is very similar to the one you've seen previously. It's how confident do you feel, and that you've got the management information that you need to self-manage your long COVID symptoms. And we asked them to score 10 being extremely confident, 0 no confidence. Next slide, please. And yeah, this is an example. These are made up names and dates and common conditions. So I saw a question on the chat about whether we do group the symptoms. For our VGCs, they've been general, really. They can have any of those long COVID symptoms or something completely different as their main or primary concern. We have found, like you do in general practice, that often it happens like buses, that you will have a group of patients with the same condition that come, or the same primary symptom that come to the group. For example, I had a lot of patients with chest pain at the last virtual group clinic that I did, which was quite helpful in a way, because I suppose that's where you have to be a little bit more clinician led, that we had to sort of start to talk about the importance of what they might need to seek help for, emergency help with in that case, and then focus on the other the self-management aspects of if it was more long COVID based. But so sometimes they do have similar themes, other times it can be different. But yes, we normally invite around, as I think Georgina said, around 10 to 12 patients. And one of the challenges we have found is attendance, as often we do see around 50% attendance. So we have looked at increasing this by sending the invites more frequently and with reminders, also planning the clinics on different days, offering them a choice of what day. Obviously, as Carol, I think, mentioned in the last talk about people working or childcare. I think that's really interesting that you're doing them sort of at different times of the day. It might be something that we need to take forward for our group, really. The next slide, please. So this is a valuation of the last 5 VGCs that we've done. We have done 9 in total over the last year, and even though the scores is quite small, there has been improvement in the confidence from before and after each VGC. As a result of these VGCs, we've also developed an interactive webinar with Helen's help again, which gives self-management advice for patients with long COVID. And this is their first appointment now in the pathway before they have the assessment, their phone assessment with the GP. They have the webinar first, which delivers a lot of information, which is more educational, but there is an element of question and answer at the end as well. So on all the different long COVID symptoms. And we found this really successful in reaching people early and reducing our waiting list. And when we came to talk to them as GPs then for the assessment call, we find that they've often started to implement some of the things that within the webinar, so that's been helpful. So the next slide, please. This is some of our patient feedback from at the end of the VGCs. give you a second to have a look at those. I mean, I think the main feeling is that we get that people gain the most by talking to others in the same boat as the previous presentation. Same feedback really. We had one feedback, another one that's not on there, saying I thought I was going crazy, but I found it highly beneficial to talk through all my symptoms with the doctor and group, and you have to adapt and change and be advised how to do that. From the staff feedback, myself and my colleagues have found it very satisfying and enjoyable. It's really helpful. You can see the patients rather than the phone assessments. We've picked up patients with their body language, if they've got their head in their hands and might be feeling quite down, then having a bad day, we'll ring them afterwards. But it's not obviously been without challenges, and we've had that challenge about attendance that we can we talk about, and also the administrative side of it is can be quite daunting and took a while to get our heads around it and get organised. But yes, overall it's been effective, and it's definitely added variety into the working week from our perspective as clinicians and facilitators. And it's quite good fun. It's really good fun actually at times, and which is obviously something we all need at the moment as well in the health service. So thank you. That's the end of our presentation. I think, is there another slide there? No, that's it.